cover epilepsy. Before going to epilepsy, we must know what is seizure or fits activity. So seizure is basically transient disturbance of cerebral function due to an abnormal paroxysmal neuronal discharge in the brain. That transient disturbance of cerebral function can manifest clinically by changes in motor control, for example, jerking of body. It can manifest with impaired sensory perception, with behavioral or autonomic symptoms. But that phenomena is transient. And what is epilepsy? When this phenomena is characterized by, or a disorder characterized by recurrent unprovoked seizures, it is called epilepsy. Recurrent unprovoked seizures are called epilepsy, while provoked seizure, for example, in case of viral encephalitis, bacterial meningitis, or due to acute rupture in any neoplastic lesion in the brain, it is not epilepsy. When it is unprovoked, then it can be called an epilepsy. Epilepsy affects about 1 to 2% of population. It's 0.5% in the US, but generally it's very common disorder. Every 1 or 2% is universally affected with epilepsy from every 100 people. As we discussed, recurrent seizures which are provoked by some reversible causes are not considered epilepsy, such as alcohol withdrawal, hypoglycemia, uremia, drugs. So these are correctable causes, and these are acute causes for causing seizure activity. And when seizure occurs secondary to these disorders, they are not classified as an epileptic disorder. So these are provoking causes of acute seizure activity, and they should not be described as epileptic disorder, but they can be called as provoked seizures. On the basis of etiology, epilepsy can be classified into 3 categories, broad categories: genetic epilepsies, structural and metabolic causes of epilepsies, and the causes which are unknown. Genetic epilepsies, majority of the epileptic disorders are genetic in origin, but these congenital abnormalities sometimes and perinatal injuries, they may contribute to genetic cause of epilepsies. Structural and metabolic causes of epilepsy are many. In pediatric age group, for example, mental retarded patients with autistic disorders, they may be associated with some structural and metabolic changes in the brain causing epilepsy. Metabolic disorders, inborn cirrhosis of metabolism like Gaucher's disease, other many metabolic disorders, steroid disorders may be associated with mitochondrial disorders like MERS. They may be associated with epilepsies. Mesial temporal sclerosis, it is a structural cause, very important structural cause of epilepsy, and very important cause of secondary epilepsy. Trauma can cause structural changes and lead to epilepsy. Tumor and any SON, space occupying lesion, can cause epilepsy. Vascular diseases, for example, stroke, can cause scar epilepsy. Degenerative disorders, neurodegenerative disorders, for example, dementia, Alzheimer's disease, and many other type of neurodegenerative disorders can be associated with structural causes of epileptic disorders. Infectious diseases, chronic infectious diseases like neurocephalus, like tuberculosis, toxoplasmosis, HIV, they can be associated with epilepsy. Generally or broadly, seizures are classified into two main categories: focal seizures and generalized seizures. Focal seizure basically for the old classification of simple partial and complex partial seizures. Now they are collectively called as focal seizures. So in focal seizures, restricted part of one cerebral hemisphere has been activated usually. There are two types. One without impairment of consciousness, which is equivalent to simple partial seizures in old classification, and other with impairment of consciousness, which is equivalent to complex partial seizures in old classification. So what is focal seizure without impairment of consciousness? Basically it is the old equivalent of simple partial seizure. So seizures may be manifested by either focal motor symptoms such as convulsive jerking. They may be associated with somatosensory symptoms such as paresthesias or tingling, or even they may be associated with some psychic symptoms. They may spread to different parts of limb or body depending on the cortical representation. So focal seizures are the seizures in which awareness remains intact. Patient doesn't have impaired awareness or loss of consciousness or like that. They may have simple jerking of a body part, for example, right upper limb, without impairment of consciousness. They may have sensory symptoms, transient sensory symptoms without impairment of consciousness. While focal seizures with impairment of consciousness, which were previously called as complex partial seizures, they have associated impaired consciousness, which may be preceded, accompanied, or followed by motor or somatosensory symptoms, as similarly they happen in simple partial seizures. But only difference is there is impaired awareness, impaired consciousness in complex partial seizures. These are the most important type of generalized seizures. Generalized seizures are basically what? That the seizure activity that originates simultaneously from both cerebral hemispheres. Common types include absence seizures, atypical absence seizures, myoclonic seizures, tonic-clonic seizures, atonic seizures. What is absence seizure? It is also known as pattern-mild epilepsy. And it is characterized by brief sudden lapses of consciousness or brief sudden lapses of awareness. For example, during conversation, a patient may miss few words, or you see that he may break off in mid-sentence for few seconds. It always begins in childhood, and it usually frequently ceases by age of 20 years or replaced by other forms of generalized seizures. So it is a childhood disorder, childhood and adolescent disorder. There are very characteristic findings of EEG in absence seizures with bilateral synchronous and symmetric 3 Hz spike in wave activity. What is atypical absence seizure? It is basically differentiated from typical absence seizure by having a gradual onset and gradual termination as compared to typical absence seizures. While typical absence seizures have abrupt onset and abrupt cessation or abrupt termination of seizure activity. There may be some changes or more marked changes in tone, which is absent in typical absence seizure, and it is accompanied by developmental delay or mental retardation many a times. Myoclonic seizures are characterized by single or multiple myoclonic jerks. Basically, they are the jerks. Myoclonic seizures are a diverse group of seizure activity which are present in many neurodegenerative, chronic progressive neurological disorders. They may again be focal, they may again be generalized. Usually in myoclonic seizures, they may have underlying metabolic causes like hepatic encephalopathy, uremic encephalopathy. Many times patients with myoclonic jerks do not have some impaired awareness or loss of consciousness, but patient may have some encephalopathy associated with myoclonic seizures. Tonic-Clonic seizures, the most common type of seizures, also known as grand mal seizures. They are characterized by sudden loss of consciousness, and in these seizures, patient becomes rigid and fall to the ground, and respiration is arrested, which is the tonic phase, initial tonic phase of tonic-clonic seizures, and usually lasts for less than 1 minute. So initially, patient become unconscious, and it becomes rigid, and patient may fall to the ground, and it is followed by clonic phase. In clonic phase, body jerking occurs. Jerking of body musculature may occur, usually occurs, and this jerking may last from 2 to 3 minutes, which is followed by flaccid coma. During seizures, in tonic-clonic seizures, patient's tongue or lip biting may occur. There may be urinary or fecal incontinence. Immediately after seizure, some patients may recover consciousness, or some patients may drift into deep sleep. Some other patients will develop abnormal behavior in immediate or post-ictal period without memory of event, which is called post-epileptic automatism. What is atonic seizure? Also called as epileptic drop attacks. They are characterized by very brief loss of muscle tone. When there is loss of muscle tone, anti-gravity muscles cannot hold the patient, so it often results in falls. That's why it is called epileptic drop attacks. What are the symptoms and signs of epilepsy? These are the prodromal symptoms. They may occur in epileptic disorders. They may precede epileptic disorders, for example, headache, mood alterations, lethargy, myoclonic jerking alerts. So these auras may precede generalized seizures by a few seconds or minutes. Basically, this aura is also part of generalized seizure activity, and it indicates focal onset from a restricted part of the brain. When there is some type of aura in a patient, or patient tells some oral symptoms before going into complete unconsciousness, it usually indicates that there is some under focal brain pathology, and in these patients you must go for imaging like MRI brain studies. These are the precipitating factors for seizure activity and for provoking seizures in epileptic patients. Very common or very important is lack of sleep. When patient miss meals at regular intervals, when there is some type of emotional stress, menstruation is also cause of, or sometimes triggers or precipitates epileptic fits. Alcohol ingestion, drugs like stimulant drugs used for recreation, like the usage of cocaine, amphetamines, they can trigger seizure activity. Fever is very important, especially in children. It triggers epileptic fits or sometimes febrile fits. Non-specific infections, systemic or serious infection can trigger seizure activity. Lights, especially flashing lights, are also very important, and they may activate seizure focus. Flickering television sets, reading, sometimes excessive reading and music may also trigger seizure activity. So clinical examination between seizures does not necessarily show any abnormality with idiopathic epilepsy. Idiopathic epilepsy, you may have totally normal clinical examination. In immediate post-ictal period, patients may have extensor planters. Presence of focal signs post-ictally suggests that seizures may have a focal origin, and these patients must be looked for underlying cause in the brain with imaging. So this is the list of investigation, very important list with a complete blood count, urea creatinine electrolytes, serum magnesium, serum calcium, liver function test, serum glucose, very important. Imaging is also very important unless it is primary or genetic epilepsy. EEG is also important to see the changes relevant to an epileptic syndrome and to sometimes to secure the syndromic diagnosis of the epilepsy. And you may find that EEG may be normal in 60 to 70% of cases interictally. Between the fifth, EEG can be normal, but during seizure activity, if you monitor with EEG monitor, it should be abnormal. Lumbar puncture is sometimes needed to elucidate or to dig out the underlying cause of epileptic disorders, seizures in the brain. What is the differential diagnosis of seizure? These are the important differential diagnosis of seizure activity with focal seizures. The important differential diagnoses include transient ischemic attacks. Transient ischemic attacks also may present with sensory and motor symptoms like focal seizures, but you can differentiate it with the phenomenology that transient ischemic attacks is a sudden instantaneous event, while focal seizure activity is basically a spreading event. For example, in patients with motor transient ischemic attacks, patient may have sudden loss of muscle power in right upper and lower limbs, while with focal seizure activity, patient may have gradual development of loss of motor activity or loss of motor power in one limb. So it is a spreading sensation, sometimes with sensory seizures may be differentiated from sudden loss of muscle, sudden loss of sensory perception in transient ischemic attacks. Migraine aura is also very important to differentiate from the seizure activity, focal seizure activity, but aura with migraine is usually associated in majority of cases, more than 90% of cases, with subsequent onset of severe headache. But in seizure activity, aura may be equivalent to simple focal activity in the brain or focal seizure activity, but they are usually not associated with the headache associated in migraine with aura. Panic attacks, especially in ladies, they must also be differentiated from focal seizures. Basically, they are anxiety attacks and they manifest with various somatoform manifestations. Rage attacks in children, especially sometimes in elderly, they must also be differentiated from focal seizures. Rage attacks are basically what? They are basically intense and controlled anger attacks due to an increased stage of hostile response to a particular event, and it is common in children but may also occur in adults. Differential diagnosis of seizure activity in adults is syncope, very important. Syncope is what? Basically it is due to a transient cerebral hypoperfusion which may cause sometimes stiffness. So it should be differentiated from the tonic-clonic seizure activity or generalized seizure activity. Cardiac disease like arrhythmias, carotid sinus disease, again it can cause cardiac syncope and it may mimic epilepsy. Brainstem ischemia may present with symptoms of vertigo and other symptoms that may mimic sometimes with generalized seizure activity like absence epilepsy. PNES basically it stands for psychogenic non-epileptiform seizure disorder, which is again not an epileptic disorder actually, and it is a psychogenic cause, a psychogenic epilepsy. So this is a list of medication list which are used as first line, second line and third line in various type of secondary generalized and focal seizure activity or focal epilepsies. So in cases with focal onset or secondary generalized tonic-clonic seizure activity, the first line drugs are carbamazepine, lamotrigine, oxcarbamazepine, lacosamide. The second line drugs again is a list of many drugs which include valproate, levetiracetam, topiramate, gabapentin, phenytoin. In generalized tonic-clonic seizure activity, if you compare from focal onset and secondary generalized tonic-clonic activity, the important drugs are valproate, lamotrigine, topiramate, levetiracetam. As you can see in the focal onset, carbamazepine, oxcarbamazepine, lacosamide are important, while here valproate, topiramate, levetiracetam are more important. Absence epilepsy, it is very unusual set of management with first line drug ethosuximide and second line is valproate. Basically it is not available here in Pakistan, so we commonly use valproate in that setting in Pakistan, where rarely lamotrigine and clonazepam can be used. Myoclonic seizures, first line drug is valproate, which is very commonly used, while levetiracetam and clonazepam are also used in cases which needs some add-on therapy. There is a list of drugs, important drugs with their dosage and their monitoring and common side effects. We will discuss about common drugs. Carbamazepine dose can be from 400 to 1600 mg, and it is a hepatotoxic drug, so you need to monitor liver function test. You need to monitor complete blood counts because it also causes blood dyscrasias and it is some bone marrow toxicity. Common side effects associated with carbamazepine are the side effects associated with cerebellar dysfunction like nystagmus, dysarthria, diplopia, ataxia, blood dyscrasias, hepatotoxicity, hyponatremia, rash. Skin rash is very important, sometimes leading to very serious skin emergency disorder with Stevenson-Johnson syndrome. Carbamazepine, it should be noted, is not a drug of choice or should not be used in patients with myoclonic seizures or with myoclonic epilepsy. It may exacerbate myoclonic epilepsy. Other important drug in this list is lamotrigine, which can be used from 100 to 500 mg. And again, the most important side effect includes sedation. It is also an important side effect of skin rash, especially when it is combined with other drugs like valproate, which increase its toxic levels, visual disturbances, dyspepsia, ataxia. Levetiracetam, very commonly used drug nowadays, a type of fancy drug and more, even not only fancy but effective drug, and also consider a relatively safe drug in pregnancy compared with other drugs. So its dosage is from 1 gram to 3 gram, and its important side effects are somnolence, ataxia, headache. Behavioral disturbances or behavioral changes are very important to notice. Other important drug is phenobarbital. Is no longer used as drug of choice, but still it is a very good and effective drug in pediatric age group with dose ranging from 100 to 200 mg. So it is very difficult, sometimes chronic side effects with drowsiness, nystagmus, dystaxia, skin rashes, learning difficulties, hyperactivity in some children. Again, you need to monitor for CBC, liver function test, phenytoin. It is not also again drug of choice for chronic maintenance therapy. Phenytoin is very commonly used in status patients as a drug of choice, IV loading dose. So again, you have to monitor for CBC, liver tests, and there is a list of these side effects associated with phenytoin. That's why it is not used as maintenance therapy for long-term management of epilepsy with oral therapies. Topiramate, nowadays it's also very commonly given drug and very effective, especially in patients who need more than one drug to control epilepsy. Dose ranges from 200 to 400 mg, and patients on topiramate should be monitored with serum bicarbonate, blood urea nitrogen and creatinine, especially in elderly patients. It is also very sometimes troubling side effect of somnolence and drowsiness. Also, you should note that patient must be monitored for the cerebellar toxicity with dizziness, ataxia, dizziness, diplopia, glaucoma. Patients with glaucoma they are really contraindicated to be used with topiramate. Renal calculi also, it increases the risk of renal calculi, and sometimes this is weight loss effect is favored by many patients, especially female patients. Valproate, the most commonly given drug for epileptic disorders. It dose ranges from 1.5 to 1.5 to 2 gram, and it is also a hepatotoxic drug, so you have to monitor liver biochemical test as well as complete blood counts, because it also causes blood dyscrasias and bone marrow toxicity. The common side effects again: nausea, vomiting, drowsiness, diarrhea, alopecia, especially that's why it's very uncommonly used in female. Weight gain is also very unfavorable side effect. Hepatotoxicity, thrombocytopenia, tremor, pancreatitis. It is usually contraindicated, or it is not usually used or avoided in women of childbearing age unless there are very certain indications or patient is not under control with other anti-epileptic drugs. Absent seizures, as we discussed before that benzodiazepine, ethosuximide, valproic acid are the drugs that are used in absent seizures. Ethosuximide again in dosage 500 to 1500 mg, and you have to monitor CBC and liver biochemical test. Myoclonic seizure activity again. In patients with myoclonic seizures, we do not use drugs like carbamazepine, oxcarbazepine, which are used with focal or secondary generalized seizure activity. Valproic acid is commonly given for myoclonic seizures along with benzodiazepine. So briefly about status epilepticus. It is a life-threatening neurological disorder with an acute or prolonged epileptic crisis. What is the status? Basically, status is two or more generalized seizure without full recovery of consciousness between them, or a single seizure lasting more than 5 minutes. Previously, the definition of status epilepticus was it was used to be a 30-minute activity with seizures. Now it has been revised. Any generalized tonic-clonic activity with loss of consciousness lasting more than 5 minutes is considered status epilepticus, and it is associated with high mortality and morbidity. Management of status epilepticus includes maintenance of airway. You have to give 50% dextrose water in case of hypoglycemia. Acutely, to halt or to terminate seizure activity in status epilepticus, we in emergency departments give benzodiazepines like lorazepam, midazolam, diazepam. These are given acutely. Initially, when patient presents an epilepsy in emergency departments, status epilepticus, after maintaining IV line, after stabilizing airway, after monitoring blood glucose and giving 50% dextrose. Patient, when it is diagnosed having status epilepticus, you must give benzodiazepine, and the usual drug of choice that we give in our emergency department is diazepam, because these drugs are not usually given in our departments. After giving benzodiazepine, and regardless of the response to these benzodiazepine, you must load patient with fosphenytoin or phenytoin in dosage with 18 to 20 milligram per kg at 50 mg per minute. If seizures continue, then we give phenobarbital IV loading dose of 10 to 20 mg, again at 50 mg per minute, or sometime alternatively we can give sodium valproate. If these measures fail, then general anesthesia with ventilatory assistance is required. If convulsions do not cease after initial 18 to 20 minutes, again we can repeat phenytoin dose. We should not repeat phenytoin dose, but we should give the drugs benzodiazepine IV loading with midazolam, and it is followed by maintenance therapy. So after loading with phenytoin and after subsequent trial with valproate, if patient is not controlled or status epilepticus is not controlled, you have to intubate the patient, and general anesthesia with ventilatory assistance is required. You cannot give a patient midazolam if patient is not intubated in there is no associated or assisted ventilatory assistant present, because patient can have respiratory depressions. All these drugs again are propofol. If patient is not controlled on midazolam, should be given. This drug is again given when patient is intubated and on ventilatory assistance. Phenobarbital alternatively can also be given with 15 mg per kg IV dose followed by 0.5 to 4 mg per kg per hour. So these drugs, midazolam, propofol, phenobarbital, these drugs require intubation and ventilatory assistance. They cannot be given in a patient without intubation and ventilatory assistance. After you have controlled the status epilepticus in a patient, long-term oral anticonvulsant drug therapy is recommended for all these patients to control the subsequent predisposition of these patients with epileptic disorder. This is a simple question that I think we have discussed just now. You can use your brain to answer me. 19-year-old man is diagnosed as having myoclonic seizure. What is the most appropriate first-line anti-epileptic drug? In patients with myoclonic seizures, we discussed what is the drug of first choice: carbamazepine, sodium valproate, topiramate, clonazepam, ethosuximide. Carbamazepine actually worsens the myoclonic seizure activity. Sodium valproate is the drug of choice, and additionally we can also use topiramated clonazepam, but if you consider the drug of choice, the valproate is the drug of choice. Ethosuximide is a drug for absence seizure activity. This was briefly about epilepsy and status epilepticus, and I would like to answer queries if you can post me on your